Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about something called psoriatic arthritis. And this is a really important condition to know because we know a bunch of different types of arthritis already. We know of rheumatoid arthritis, we know of osteoarthritis, we even know that there's something called septic arthritis, and now we need to be able to differentiate a different type of arthritis called psoriatic arthritis. Again, this is in our seronegative spondyloarthritis chapter. Why? Because this is seronegative. That means the serum is negative for a rheumatoid factor. That's kind of a defining feature of these conditions. It also has a strong association with HLA-B27. So right off the bat, if you remember from our overview video, those are a couple of the key things we want to know when we think about these pathologies. Now we're going to talk about some of the details to really differentiating these from each other or from other similar pathologies that could trick us up on test day. So when we think about the pathophysiology here, we said this is a seronegative spondyloarthritis, and we talked about what that means. And this condition occurs when inflammatory markers such as interferon alpha, interleukin 6, tumor necrosis factor, lead to increased T cell recruitment to the skin and joints. So the idea here is that some patients have a predisposition, or when we think about the etiology, they might have genetic components. They might have that HLA-B27 component. This can be combined with some environmental things that lead to an overreaction or overinflammation in the body. This is going to lead to increased T cell recruitment. And what's that going to do? Well, it's going to lead to increased osteoclast activation and ultimately osteolysis of the joints. What that means is the destruction is going to occur. Osteolysis is destroying of the bone. And so the body's overabundance or overproduction of inflammatory markers essentially leaves the body to destroy itself. Now, when we think about the classic presentation here, this is usually going to be in kind of that 30 to 50-year-old age range. So not super common in a 12-year-old, not super common in a 75-year-old. Does this mean this can't occur? It means it can't be their first diagnosis at that age? Absolutely not. This is just the most common age range that we typically see this condition in. We also need to know that this often starts out as an asymmetric oligoarthritis. Remember in the overview video, I said a lot of these start out this way. It's asymmetric. So it might have one knee affected, but not the other. It might have one hand affected, but not the other. And it's an oligoarthritis. There's typically multiple joints that are affected. We compare this to something like a monoarthritis where only a singular or one joint is affected. However, in psoriatic arthritis, as you can see, in later stages, we actually develop a symmetric polyarthritis. So I think about this as the arthritis progresses, right? It might just be in one knee early on, but then later on, as the disease progresses and more tissue is destroyed, more bone undergoes osteolysis and damage, now it's affecting both sides. Now it's affecting both knees, similar to how it's affecting more places in the body. We've gone from an oligoarthritis, meaning it affects a few joints, to polyarthritis, meaning it affects many joints. And again, I think about this as a progression of the disease. It's also important to know that there are some other classic findings here, including skin psoriasis, right? This is called psoriatic arthritis. So I think about it as a hybrid condition between psoriasis, those scaly plaques that we would typically see on surfaces in the skin, with the arthritis, which we know as being inflammation of the joints. A very classic physical exam finding I like to give you on test day is something called pitting nail beds. So if you draw your attention to this image right here, and you look at this nail bed, you can see kind of a bit of a pit. If you were looking at this from a different view, let's say you were looking at it this way, this being your eyeball, you would see kind of a scooped shape appearance in the nail. This is indicative of a pit. So this physical exam finding, right? If they're showing you nail beds, right? If they're showing you an image on the test, they're showing you it for a reason. It's not there for no reason. If it looks like there's something like this going on where they're showing you these pits, you want to associate it with this condition. Maybe they're not giving it to you really obvious. Maybe they're not talking about the arthritis the patient has. Maybe they're just talking about some of these external findings and they want you to draw that connection like, hey, all of these other things are also associated with psoriatic arthritis, even though they're not specifically telling me that the patient is having knee pain. This is the kind of clinical reasoning that I want you to be able to get to when test day rolls around. Some other unique findings that we also need to know include enthesitis, which we talked about in the overview video. This is going to be inflammation where a tendon actually meets the joint. We talked about the Achilles tendon being the classic example here. Dactylitis, again, going to be your sausage digits, and you can draw your attention to this image over here. This is a really nice picture of dactylitis. You can see how much thicker this finger is right here compared to this one right here. So you start to develop more sausage or widened fingers or digits in the extremities. This can be in the fingers or the toes. You can also see other things such as uveitis. This is a really important one to know because, again, there are a lot of things that can be associated with this physical exam finding. Yeah, you can just have uveitis by itself, but it can also be associated with things like sarcoidosis, or in this case, psoriatic arthritis. So again, here's an image of uveitis where you can see the extreme inflammation in the uvea. Now, when we think about our diagnostics here, really important finding to know about is the x-ray finding of a pencil and cup deformity of the DIP joint. And so if you draw your attention over here to our x-ray, you can recall we have our PIP joint, which is our proximal interphalangeal joint, and our DIP joint, which is our distal interphalangeal joint. So the pencil and cup deformity is essentially this finding that this is the pencil tip right here, and this is the cup right here. That is to say, the proximal bone, or the one that's closer to us, is kind of creating a pencil shape, and it is going into the distal bone that is creating more of a cup shape. This is a very classic finding of psoriatic arthritis. Now, some other key findings that you can also see include paravertebral ossification. Again, a little bit less specific for this, right? It just means that there's bones being formed around the vertebra. And again, we've talked about how a lot of these conditions are associated with findings in the vertebral bodies or changes in the vertebral bodies. And so this is just an example of that here. When we think about the labs, you're going to have increased CRP and ESR in addition to uric acid. Increased CRP and ESR are inflammatory markers in the body. And we said from the pathophysiology here, right, drawing this all together, this is an inflammatory condition. So it makes sense that these molecules are going to lead to increased inflammation in the body, and thus we can see them in the serum markers in the ESR and CRP. Now, once again, here we can see that very classic association, right, that HLA-B27 association with a lot of these seronegative spondyloarthritis. And this is typically rheumatoid factor negative. Why? Because that's what makes it seronegative, right? We don't have that rheumatoid factor. We don't have that IgM, that autoantibody that is binding to the FC portion of IgG. That's how we're kind of classifying these. We put these in a group to say these are negative for rheumatoid factor. And so keep that in mind on test day. For psoriatic arthritis or the seronegative spondyloarthritis, rheumatoid factor is typically going to be negative in these conditions. And for the purposes of testing, that's how we want to categorize it. Doesn't mean there's not exceptions to the rule, but that's the simplest way that we want to approach this as we're preparing for our test day. We want to learn about the most common, the most likely things to occur first, and then we can talk about all the random zebras that we'll see in medicine later on. Now, I'll just make a quick note on how we actually classify this. It's not super important for test day, but I want to be somewhat comprehensive here. The classification criteria for psoriatic arthritis is called the CASPAR, the CASPAR. And this is basically a scoring system that includes both clinical features and diagnostic studies. Some clinical features can include patients who have psoriasis. That's a clinical criteria that makes having psoriatic arthritis more likely. Patients who have a history of psoriasis, patients who have dactylitis, or have something called psoriatic nail dystrophy, right? This constellation of findings make it more likely that the patient has psoriatic arthritis. You combine this with some clinical findings or some diagnostic studies, such as the negative rheumatoid factor or the X-ray findings of the pencil and a cup deformity. All of these things are going to lead to a higher score, which would lead to a higher likelihood of the patient actually having psoriatic arthritis. Now, when we think about our management here, it's mostly going to be symptom management. So we're talking about anti-inflammatories, disease-modifying anti-rheumatic drugs, one of the classic ones being the TNF-alpha inhibitors, and intra-articular glucocorticoids. Again, there's no treatment for this condition. It really is about managing symptoms. So if we have arthritis and we have inflammation in the body, it makes sense that we're using a lot of things that are kind of curbing that system, right? We're decreasing the inflammatory response, we're decreasing the immune response in the body to help these patients with their symptoms and hopefully have a better quality of life. So a classic vignette they can give you for this question includes something along the lines of a 28-year-old patient presents to the emergency department with a chief complaint of new onset hand pain. The patient reports morning stiffness in the fingers, which interferes with the patient's job as a secretary. The patient has a known history of psoriasis, which is appropriately treated and under control. The question could then ask, which of the following additional physical exam findings might be present in this patient? They can give you a lot of different option choices here, talking about different rashes, but the key answer choices you want to be on the lookout here for this type of question would be either uveitis, dactylitis, or likely they like to ask about this pitting nail finding, right? We talked about this previously. If you're looking at this, you see this kind of scoop shape in the nail. This pitting nail is very classic with psoriatic arthritis. So just a really quick summary for this video. We're talking about psoriatic arthritis. Remember, this is one of our seronegative spondyloarthritis, meaning it is negative for the rheumatoid factor IgM antibody. Pathophysiology here is basically a process by which inflammation destroys tissues in the body, ultimately leading to a variety of physical exam findings, which we talked about here. For diagnostics, the key one I want you to know about is the X-ray finding with a pencil and a cup deformity. Again, you can imagine that a pencil is going into a cup here, and this is a very classic finding that will show you when they show you an X-ray of the hand. Now, when we talk about management here, as with the other seronegative spondyloarthritis conditions, there's not really a treatment option per se. It's really dealing with symptom management. So anti-inflammatories, disease-modifying anti-rheumatic drugs, DMARDs, such as TNF-alpha inhibitors, and intra-articular glucocorticoids can be useful for these patients to make it tolerable for them to deal with the symptoms that they might be experiencing.